I believe one day science will again become valuable. Instead of an opinion based on absolutely nothing other than big I's and little U's. So what I want to do is take you through the rest of the organs of this autopsy that I performed. And on this particular, I'm going to start with this heart. As you can see, the heart is extremely normal in this middle-aged person. There is absolutely no abnormality within this heart. And I'm going to show you the coronary arteries next. But these are very normal cardiac muscle cells. I usually take sections of the septum, the left ventricular myocardium, and the right ventricular myocardium. And they all represented these normal changes here that you see. Very normal heart. So I'm going to go to the next slide to show the coronary artery. So next, I usually take a section of the coronary artery. Here is one coronary artery. You can see the lumen there, and you can see the wall there. Not much other than a little atheromatous change in this middle-aged male, but not bad at all. Very widely patent. And if I can go to the next, let me see, sometime I may, okay, let me just, okay, and here's the, no, I'm not sure yet. Hold on a second. Let me just get to the, let me just do this. I usually take a section of the left coronary artery and the right coronary artery. So here's the second artery, a little collapsed here. But you can see here too, here's the lumen here, and there's not much in the way of significant atheromatous change. There's some mild atheromatous change, but not that major. As you can see, the vessels are very widely patent. So I'm going to go to the next slide, which would be a section of the liver. Here's the section of the liver. As you can see, there's some zonal necrosis. So here's a central vein there, and right next to the vein, you're going to start seeing some necrosis. I interpret this as ischemic necrosis of the liver, perhaps due to cardiogenic failure or shock. And you can see that the other liver cells are nicely developed and normal. And I'm going to show you, here's a portal triad there. You can see not much in the way of inflammatory cells. And although there's a mild steatosis, you don't see any significant steatosis. So not much in the way of fatty change. There's a, okay, here's a nice portal triad here. And you can see that the liver cells are very intact and normal, other than, again, the zone 3 and zone 2 liver cells showing some ischemic necrosis. And that's, again, due to the terminal phase of cardiogenic shock. There's another portal triad. Okay, so normal liver, a little scarring around the central vein there. But again, and you can see the ischemic necrosis there. Well, not now. No, not there. Let me show you some good necrosis so I can make a believer out of you. So far, so good. And it was very patchy necrosis. There's a, okay, keep on going around until we get some good necrosis. You can see that this liver is very healthy otherwise. Okay, there's a central vein, and I'm going to go down even closer so I can show you the liver cells up close to convince to you. That's just a little biostasis there. And here's, you can see some necrosis of the liver cells. That's ischemic necrosis. There's a central vein. And now we go with some necrosis. So viable liver cells there. Necrotic liver cells there. Here's a low power view of the spleen. Now you see in the middle is a good white pulp. That's with the lymphoid tissue. But look how the red pulp is expanded by histiocytic cells. And I'll go down and take a closer look. But this is very abnormal spleen where it looks like the lymphoid component is reduced. So that's a part of the lymphocytopenia that one will see. And I'm going to go even closer to show you the expansion of the red pulp which is comprised essentially of histiocytic cells. If I can get it in focus. Let me see if I can go even lower. Higher power. Well, you can see a lot of debris. You see some hemosiderin. You see some histiocytic cells and even some lipid-laden cells. And look how the lymphocyte component is much reduced. Again, this is a part of the pathology change with COVID. Okay, and most of the lymphocytes you probably see here, there are a few B cells, but a lot of them are probably T cells. Because remember, the virus has an effect on a population of B lymphocytes. Okay, so, and let's see if we can find, there's another white pope with lymphocytic cells, and then the red pope being the expansion around that, with histiocytic cells, hemosiderin cells, and so forth and so on. Good lipid-laden cells there. It's a good section of the spleen. And now this is 9 days after death. So you can see that you can still tell a lot about cells even 9 days after death, as long as it's being maintained in a good frigid temperature. Here's a nice section of stomach as I go down, just to show you the histology of it. There's a little autolysis going on here, because again, the cells start dying after so many days of death. But you can see some nice parietal cells. This is very normal looking stomach here. Not much in the way of inflammatory component. So when this all goes along with what I saw grossly with a normal stomach. Not much in the way of gastritis at all. Very normal looking stomach. This is the fundic portion of stomach. Probably a little fundic / antral portion of stomach. But very normal looking stomach here as I continue to peruse. Here's a section of small bowel. You can see the tall leaf-like villi, very normal. Obviously, autolysis going on here because, again, the person was dead and you'll start seeing some dying of the cells. But if you see there's not much in the way of inflammatory pathology here or even neoplastic. Very normal, nice-looking small bowel residual villi. Very normal. Again, most people would say the person probably had some sort of underlying chronic disease, and there's absolutely no evidence of that in these histology section, and even in the gross examination. The other organs other than the lungs were perfectly normal, and obviously the hematolymphoid system, the spleen, and I'm going to show you a lymph node eventually, and the bone marrow. But this is normal small bowel intestine. Okay. So here's a section of appendix. Very normal looking. Oh, that may be small bowel. No, that's appendix, okay? So you can see the lymphoid tissue there in the wall, the glands. Very normal looking appendix, but notice not much in the way of lymphoid tissue. So you can see some scattered lymphoid tissue, but not much. Usually the appendix has a lot more lymphoid proliferation, particularly in a viral infection. But this is relatively normal appendix. Some scattered residual lymphoid aggregates. But this would be normal appendix. Not much away in appendicitis. But it seemed to me, in my opinion, that there is reduction in the lymphoid tissue. Okay, again, that correlates with the pathology of COVID-19. You should see a little more exuberant lymphoid response in a person infected with COVID. A viral infection. Okay, we're getting a little more into it now. This would be almost normal looking appendix here. And this is a relatively middle-aged man, so older, so you're not going to have a lot of activity within the appendix. As we get older, the appendix almost become fibrotic-like. Okay? Now, this is the kidney. Now, the person had a history of hypertension, but I think it was probably very well controlled based on some of the clinical data that I saw. But you can see relatively nicely intact glomeruli, and I go closer, but most, if you look at the surrounding tubules, they are necrotic. So this is acute tubular necrosis, but I'm just going to go and show you. Otherwise, this kidney looks very good, very good. You know, a middle person, typical middle person would love to have a kidney like this. And in fact, on initially on presentation, his kidney functions were very normal. But obviously with progressive cardiogenic shock, his kidney took a beating, and you can see the necrosis of the renal tubules. But the glomeruli, you don't look that bad. So maybe a little mild mesangial cell hyperplasia, but other than that, and that goes along with a little hypertensive disease. But this is nothing of significant pathology in this kidney other than, again, the effect of shock, lack of perfusion from cardiogenic shock to the renal tubules. Not much in the way of inflammatory cells here, not much in the way of scarring to suggest some sort of chronic kidney disease. No, this was not bad kidney disease. And then we're getting into there's a glomeruli that was a little more, damage from perhaps hypertension, but still not bad. Still not bad. I mean, most people would love to have a kidney like so. Again, obviously affected by lack of perfusion towards end of life. Very nice looking, normal looking kidneys. I usually take several sections of the brain. I'm not going to go through a lot of the section of the brain because it was very normal brain, and I think I showed you the gross because I like to keep my stuff transparent. So people go, oh, he don't know what he's talking about. And if somebody want to argue that this is abnormal brain, so be it. This is very normal brain by histology, and even perhaps functional during life. Now, I'll remind you, this brain is after a person been dead for 9 days, of course, maintained in frigid temperature. So you can see very nice preserved cells, nice, normal and happy looking pyramidal neurons. Look, some white blood, not white cells, but some glial cells in the white matter, astrocytes and so forth, microglial cells and so forth and so on. But very normal looking brain. And I'm just going to show you a quick view of the cerebellum. So here's the cerebellum. Look at the nice, normal looking neurons. Very happy looking neurons. Obviously going through some little hypoxic change, little red neurons change, but not bad. You still see them there. They're not dropped out there, but this is very nice looking normal cerebellum tissue. You know, oftentimes, you can come up with every opinion you want to, but the autopsy, that's very nice looking. Look, just get you excited when you see happy looking neurons like that. That's a very happy looking neuron right there. Pyramidal neuron. Good histology. This is not from a textbook. This is a real human being showing real histology. There's some red neurons scattered about. So obviously the person did have some hypoxic changes in the brain, but not bad. And there are some edematous changes as well, because he was fluid overloaded from the doctor's standpoint, giving him a ton of fluid. But other than that, the brain don't look that bad. Obviously, a few scattered red neurons, but otherwise the neurons look pretty happy looking. All right. So now I'm going to go to the bone marrow. Now, most pathologists don't even sample marrow tissue for autopsy. I do. So you get some cortical bone here, and then you see the medullary bone, and you see the marrow elements in between the medullary bone, the bony spicules, the trabeculae. And then we go down, you can see that that's nice cellular marrow, normal cellular marrow, about 40% cellularity. You can see some scattered megakaryocytes. You see, let me go down so I can show you I'm not making up these cells. You can see some nice myeloid cells, erythroid cells, and there's a megakaryocyte obviously right there crushed. And but a lot of, and this would be obviously, like as I explained in my report, this is more like a myeloid to erythroid ratio of probably 3 to 5 to 1, so very normal. You don't see much in the way of lymphoid cells. A lot of these are myeloid cells and erythroid precursors. So I keep on going over. There's a nice megakaryocyte too, right next to each other, right there in the center of the field. Those are megakaryocytes, platelets, derived cells. And see the myeloid cells around it. So this was a happy looking bone marrow. There are some more megakaryocytes, but not much in the way of serous atrophy or some sort of chronic disease, and not even way of lymphocytosis, which again, one would suspect some sort of lymphocytosis in the marrow with a viral infection. So more evidence of lymphocytopenia. Okay. Now I'm going to show you a hilar lymph node, again, showing more features of viral lymphadenitis, more megakaryocytes there. We've got 3. They used to say when you see that many close together, there's evidence of megakaryocytic hyperplasia, but I don't see that being an issue here. I think you just see, every now and then, if you go to a good area, you'll see a collections of megakaryocytes. But in this, it's not like overwhelming close together megakaryocytes. As we go in several other fields, you don't see any megakaryocytes. Okay? I'm just trying to teach. I hope y'all getting some stuff from this stuff, because a lot of time, even medical students don't get this much information. But this is beautiful cytology and histology. And finally, here's a hilar lymph node. And I'm just going to peruse around first, and we'll go down. That's beautiful lymph node architecture there. And you see a couple of follicles, germinal centers, and stuff like that. And then obviously there's some lymphocyte. Now there is some lymphocyte reaction here going outside of the capsule. And here's to show you that it's hilar. There are some bronchial cartilage there. See if we see some tissue with that. Epithelium, probably not. Yeah, because this is all in the peribronchial soft tissue. These are hilar lymph nodes. And you can see, and I'm going to go down closer so you can see more of the pathology of this lymph node, but you can see a little pigmentation in this lymph node, which is normal around the bronchus. Again, this person lived in the city. So let me go down just to show you. But the follicle germinal centers look like they're kind of involuted. In other words, you don't see the mantle zone with it. You see just basically the germinal centers. And there's some scatter. And that goes with the pathology now of this Covid-19. It affects a certain population of B lymphocytes. So this is good pathology, man. This is really good pathology. And as we go closer, I'm going to show you some actually necrosis of some of the lymphocytes. If I can go further. When I get to an area, I'll go down and show you some necrosis of the lymphocytes. And that goes with some lymph nodes, with viral lymphadenitis, you're going to see some necrosis of the lymphocytes. Okay, but let me see if I can get to an area before I want to waste your time. But that's a nice germinal center there. But look at the mantle zone again. And here is where you're going to probably see some necrotic lymphocytes. Okay, so far so good. That's all good. That's all good. But you start seeing some evidence of necrotic lymphocyte there. You see the viable lymphocytes, and then you see in between some necrotic lymphocytes with the pink cells outlined. Those are necrotic lymphocytes. And there are some more necrosis there around some of the pigmented cells. So let me go back to the viable cells. Those are viable cells. And here are some necrotic cells. Now, some of this is autologous as well. The person was dead, died 9 days prior. But this is true pathology. This is viral lymphadenitis as well. Because again, you see viable cells, and then you see the necrotic cells. Thank you for listening to the video. I hope you learned something. But always remember that the pathology holds the scientific key to evidence of disease, its origin, its development, and disease manifestation. Thanks again. That's some nice, beautiful pigmented cells here in a hilar lymph node. Okay? Thank you for listening.